Hello, everyone. I'm Dr. Carmen Pugliafito, and today I'm happy to welcome back to Retina Synthesis Dr. Arshad Khanani, who is the leading clinical investigator in retinal pharmacotherapy in the United States. Arshad, welcome back.
Thank you, Carmen. It's always a pleasure to speak with you and be on your show.
We're going to talk today about intravitreal gene therapy for neovascular AMD with the 4DMT product. Can you just tell us what the goal of intravitreal gene therapy is?
Absolutely. So, Carmen, the real goal is to use it as a drug delivery platform to chronically control chronic diseases, right? So here we are looking at neovascular AMD and DME with 4D-150, and the idea is that you use the AAV vectors to take a gene that now the gene gets expressed into the cells of the eye, and you start producing a protein that can inhibit a disease. So in 4D-150 uses this novel R100 vector, which has dual transgene gene therapy, takes the transgene for aflibercept as well as the interference mRNA for VEGF-C, and you inject this in the eye, and now your cells in the eye are transfected with this vector and it start producing the two transgenes I spoke about. So really a drug delivery platform, not a gene replacement therapy that we do for inherited retinal diseases.
Right. So this is a bispecific treatment approach. Is that correct?
Yeah, so it's a dual targeted. So it's not a bispecific in that sense that it's not one molecule with two targets like faricimab, right? This is two different transgenes. So you are producing, aflibercept in the eye, but you're also producing interference mRNA against VEGF-C to decrease the production of VEGF-C. But what we have also seen is that in this, preclinical model, that the inhibition, the interference mRNA piece being there actually increases the expression of aflibercept, and we don't understand why, but basically it's there to help suppress VEGF-C, but also increases the expression of aflibercept from 4D-150. So yeah, this is a dual transgene gene therapy.
So tell us a little bit about the protocol and the study results. There have been a number of studies using this molecule.
Yeah, definitely. So the two studies that have read out is obviously the PRISM study in wet AMD and then the SPECTRA study in DME. But I think our focus of our discussion today is wet AMD because that's the program that's in phase three pivotal Forefront 1 and Forefront 2 studies. So PRISM study, I recall helping with the design of that or 5 or so years ago, and we were the first site to actually inject the first human with 4D-150. And obviously at that time, we had some complications from other gene therapy programs, so we were a little nervous, but we used the learnings from the other programs in terms of steroid prophylaxis, in terms of injection technique and all these other things. So PRISM is a phase 1/2 study, which is looking at, obviously the safety and efficacy of 4D-150 in patients with wet AMD that were previously treated. Patients in this study receive an aflibercept injection. They have to show a response. After they show a response to aflibercept, they received 4D-150. There's a 20-week topical difluprednate or Durezol taper. What we learned from prior other gene therapy programs is that we need to have a long and slow taper of steroid when we inject billions of vectors in the eye so we don't get inflammation. So that is essentially the design of PRISM. And recently at Angiogenesis, I presented the 18 to 24 month data from the PRISM study looking at the phase 1/2A patient population, which was severe disease population because those were first in human. We wanted to make sure the treatment is safe, and only patients that would sign up for that are the ones that are getting injections essentially every month. The mean injection over the last 12 months in that group was 10.2, and their CSTs were around 4 and 25. Then we have the second group of phase 2B, which was looking at broader patient population, mild, moderate, and severe all combined. And those patients had much less treatment burden, on average about 4.5 injections, and their CSTs were about 336. And then the last patient is the phase 2b subgroup, which is the phase 3 comparable patient population, which is recently diagnosed. And those patients were better control. And I think it's important, Carmen, when we look at the data to look at those three different subsets that are part of PRISM study.
Well, what about the severe group, those patients getting 10 injections a year? Wow.
Right. So when you look at those patients, basically what we saw was we saw maintenance of visual acuity and CST over time. So remember, Carmen, we were looking at two different doses of 4D-150, the 1E10 and then the 3E10. And the reason we started at low doses was because of the fact that we have seen a dose related adverse event profile in the other gene therapy programs. So we actually started PRISM at 3E10, and then we saw that efficacy was good. So we lowered it to 1E10. And now we have data on both of those doses. And then we also had a aflibercept control arm in the dose expansion phase of PRISM, where we had 10 patients who received Q8-week aflibercept instead of the gene therapy as a control. So what we saw was in the severe patients who were receiving, either 1E10, 3E10, or the Q8-week aflibercept, there was a reduction of 71% in terms of treatment burden. So when you look at, over 2 years, aflibercept group got around 14 0.8 total injections, while the high dose 3E10 group only got 4.3 injections. So remember, these are patients who have received 10 injections in the prior year. I think when you look at the data, Carmen, there are two things that people pay attention to for gene therapy, but I think it's good to kind of explain that. Number one is injection free. I think a lot of physicians and investors kind of get fixated on injection free number. I think the injection free number is important, but I think the treatment burden number is actually reduction is more important because we're getting a certain level of protein production in the eye, and if you're much higher need than what you're producing, you're going to need some supplemental. Gene therapy is not going to be a cure for everybody. We're actually not looking for it. We are using it as a drug delivery platform for sustained disease control and better anatomic and hopefully vision outcomes over time. So when you look at, the severe population, 59% of the 310, patients receive 0 to 2 injections. So that's like over half of these patients are receiving 0 to 2, and 22% required no injections over 2 years, again, coming from 10 to 0. So I think, the data was really promising that even in severe patients, gene therapy can significantly reduce, treatment burden for our patients. So any questions on severe before we go to the broader patient population?
No, I think the point that you made about decreasing treatment burden is important because these patients need to be monitored in any event.
Exactly the point. They have, you're not going to give gene therapy and forget about it. I think you're going to manage these patients. And again, we treat and extend, so we figure out the sweet spot for these patients. But since it's a one-time injection, I think any patient with any spectrum of disease, if payers allow us, can receive this. And now we're going to have 50% plus patients based on the need go injection free, while the others will enjoy the benefit of not getting injections every 4 to 6 weeks, but rather maybe every 4 to 6 months.
What about visual acuity in this study?
Yeah, the visual acuity. So remember, these are previously treated patients. So visual acuity and OCT are essentially stable. So we're not seeing an increase or decrease because these are already previously treated patients. So their visual acuity was already optimized. But one thing, Carmen, is when you look at OCT, the aflibercept group is doing the seesaw like it usually does, while the 4D 150 group is not doing the seesaw, right? And obviously the reasoning is that you're having sustained protein production in the eye, which is leading to good disease control in these patients, especially the severe patients should fluctuate a lot because they need a lot more anti-VEGF, but having 4D-150 on board as a baseline therapy is really helping these patients control the disease.
So what about in the less severe eyes?
Yeah, so the second portion, the phase 2B portion we looked at is the broader. So this one had severe, mild, and moderate all across. Again, we saw this that one did not have a control arm, so we saw maintenance of visual acuity and CST in the 3E10 group. One thing that is nice to see in all this data set, Carmen, is a dose response. The lower dose it does worse than the higher dose, which is 310. So I think we see that there's a dose response here, which shows that the more vectors you inject, the more protein production you get. So in this patient population, Carmen, 50% of patients were injection free at 18 months. Because this cohort was later, we don't have the 24-month data. We have 18-month data. So 50% injection free for 18 months, which is really great to see. And then 76% of these patients required 0 to 2 injections. So again, coming in with around 4 to 5 injections, and part of it was many of these was recently diagnosed. It wasn't that their need was 4 to 5, but many of these were just recently diagnosed, so they didn't get enough injections before they got into the study. But I think you're essentially saying, hey, half of the patients at 18 months don't need any treatment, and 75% or so only need 0 to 2. So again, very positive data set looking at the broad patient population.
What about inflammation?
I think inflammation is a good question. We always worry about gene therapy related inflammation. The good news is that when you look at the data, the rate of inflammation is 2.8%. And when you look at where is this inflammation is happening and what kind of inflammation is happening is very promising to see that the inflammation is very, very mild. And if it happens within the first 28 weeks. So in the long-term data set I presented at Angio, there's no new cases, which is great. And when you look at those, 2 patients who had really had the inflammation, so we have a total of 71 patients for the analysis from 1.5 to 3.5 years. And one patient had 1+ vitreous cell at a single time point. Actually, 2 patients had that, and that's pretty much it. And with the 20-week taper, we are controlling inflammation really well. 99% of patients completed the prophylaxis, and 99% remained off the steroids after that. So very, very promising. Of course, we have to see the full data in the phase 3 trials, but I think for a gene therapy program that's intravitreal, I think this is the best data set I've seen. And I think it goes back to the vector they're using. It's called R100. It's more retinotropic. When we use vectors that go mainly to the front of the eye, to ciliary body and the iris, that's where we start running into trouble with inflammation and pigment release over time.
What was the inflammation prophylaxis regime again?
It was
Durezol,
20 weeks of Durezol, yes.
right? And are they continuing that in the phase 3 trial?
Yes, nothing has been changed in the phase 3 trial. The only thing that's changed in the phase 3 trial is that the patients are treatment naive. And I'll tell you why. Because the third cohort, we didn't talk about the phase 2B patient population where the diagnosis was less than 6 months. Those patients actually did really well. They actually gained some vision, their anatomy was well controlled, and 73%, Carmen, did not require any treatment or 18 months. And
Yes.
87% required 0 to 2 injections. So we really kind of picked the best patient population for the regulatory phase 3 trials, knowing that once it's available, you may be using it in all patients because it's working for everybody. But the best shot on goal in terms of getting the highest rates of injection free is those recently diagnosed. So that's the only thing that's changed. The naive patients come in, they get an aflibercept, and then they have to show a response. They get another aflibercept, then they get 4D-150 or a sham injection, then one more aflibercept after that. to kind of load the patients up. And then they get a 20-week of steroids, and then they have disease activity criteria, and then the primary endpoint, obviously, at 1 year. So the Forefront 1 study, Carmen, is already fully recruited. And the Forefront 2 study, which is a global study, Forefront 1 was just North America, it's ongoing. And the data from Forefront 1 will come out in the first half of 2027, and then the Forefront 2 will be in the second half of 2027.
Where do you think intravitreal gene therapy is going to fit into the program of neovascular AMD management, let's say in 5 years? Where do
Yeah.
you position it?
Yeah, I think, Carmen, obviously, let's talk about that without the barriers from payers, right?
Right.
So the pricing and payers is out. You have patients that are coming in every 4 to 6 weeks. They will be a perfect fit because now they can go, much longer between their injections. You have patients that are coming every 8 weeks. They're a great candidate because half of them may go injection free. And then you have patients that are coming every 10 to 12 weeks. You talk about, well, the risk and benefits and monitoring upfront because it does require monitoring initially for 20 weeks, if you're on steroids. But then there's a good chance that two-thirds or, even three-fourths of them would go injection free. So I think when I look at gene therapy, I think the biggest barrier is the payers and coverage. But if you take that out, and if the patient, doesn't have glaucoma or bad IOP spikes, then I think many of the patients are going to be eligible, irregardless of their, treatment regimen, because it's a one-time treatment, and you're able to have this baseline level of anti-VEGF, and then if you need more, you get more with pulsatile injection. And as you said, you're still going to monitor these patients. So I think it fits in a broad spectrum of the patients. Obviously, if the efficacy and safety pans out in the phase 3 trials.
Well, this is exciting. It really is exciting. And I think, we have the subretinal approach for this as well. And it'll be interesting to see how this all pans out.
I agree with you, Carmen. I think subretinal approach is going to be the first one to read out later this year. And we have been part of that program also for a while. Patients who cannot take steroids for 20 weeks, patients, who have other, reasons that we cannot do intravitreal gene therapy. Really, I mean, it's other than glaucoma or not able to take the drops. I think there's not much too many exclusions. Subretinal gene therapy, we don't have that risk of inflammation, right? We go in, we put the bleb under the retina. Now, obviously, patients that are studied in the phase 3 Ascend and Atmosphere study are pseudophakic, so they have to be pseudophakic. I think phakic are fine too. It's just that they're going to get a cataract quicker. But I think subretinal gene therapy is the first to read out. I think it's going to create a really good momentum for our field. So I hope that data is positive. Yes, it's not for everybody because it requires a surgical procedure, but I think it's going to validate that gene therapy can be used as a drug delivery platform for patients with neovascular AMD.
Is there anything special about the intravitreal injection technique here?
That's a really good question. So I have my own technique but routinely it's done the similar way. But what we introduced in the PRISM program is laying the patient back for 15, 20, 30 minutes after the injection. I personally, Carmen, like to inject deeper because my idea is that I need to deliver the vector to the retina or closer to the retina versus to the front of the eye. So you can imagine if you do a very, not deep injection and now you're injecting very close to the iris and ciliary body, you may get transfection of those areas. So personally, my technique is, and again, we don't have a study to prove it, but I lay the patient, I go deep and I inject slowly. And then, of course, per protocol for the 4D program, we kind of lay the patient down for 15, 30 minutes, somewhere there to kind of make sure the vector is going more towards the back than the front. But other than that, it's your routine intravitreal injection. You won't even know if it's gene therapy or not. It's just clear liquid is 50 microliters and you just inject.
Well, that's exciting. Arshad, thanks so much for coming on Retina Synthesis, and we'll be following this field very closely.
Always a pleasure, Carmen. You always ask great questions, and I'm really excited about gene therapy for neovascular AMD, and I think it will become a reality here in the near future. I'm also looking forward to the subretinal data later this year and to 4D-150 intravitreal data next year. Thanks for having me.